Hello, everyone, and welcome to this live Q&A on mpox. My name is Nika Alexander. I'm part of the communications team here at the World Health Organization, joining you from Geneva today. Today, we're going to answer your questions on mpox, or monkeypox as it used to be known, which WHO has just ended the emergency, which we called for mpox last year in July. So we'll talk about that and also about the disease itself. Today, I'm joined by three people: Dr. Rosamund Lewis, who's technical lead for mpox at WHO. Also, Mr. Andy Seal, who's an advisor in WHO's Department of HIV, Hepatitis, and STI. Welcome, Andy. And Mr. Ochonye Bartholomew Boniface. He tells me he's known as OBB. He's the country director for Nigeria with Heartland Alliance International. Thank you all for being with us today.
Thank you.
So we're here to answer questions, first of all. So just to remind you, if you're watching us on Twitter, you can tweet a question using hashtag AskWHO. If you're watching on Facebook, LinkedIn, or YouTube, you can just put your question in the comments. We have our team of colleagues from the social media side of the house, which are looking through, sifting out the questions, which they will send to us. So you can ask us directly whatever you want to know. Just a reminder of what mpox is. So mpox is an illness caused by a virus. It's one of its most common symptoms is this rash that people can get. A rash has blisters or sores, and they can affect face, palms, hands, soles of feet, the groin, the genital or anal regions. And they can be quite painful as well. So those are the main things people know about mpox. And then the reason we're doing this today is yesterday there was a big announcement from WHO. On Wednesday this week, a group of experts that WHO has been convening regularly met to look at the situation and see if the increase in mpox cases that we saw last year, and at the time we realized an emergency. Are we still in an emergency phase? A group of experts agreed that we've actually passed the emergency phase, and they advised WHO's Director General, Dr. Tedros, to end the emergency, which is what he announced yesterday, and why we're coming to you today, because we figured people might have some more questions. So I'll start with you, Rosamund, and ask, what were the reasons? You were sitting in on the committee's meetings and you heard everything that was discussed. What were the reasons the committee gave for advising that the emergency can be called over or finished?
Thank you, Nika. As you have reminded us all, this outbreak of mpox occurred last July and really surprised the world with many, many cases beginning in Europe, which was completely unprecedented. There hadn't been this many cases in one place at one time outside of the original setting of mpox, which is in different parts of Africa. So this was a big surprise, and the world needed to react because it's an infectious disease. It's an infectious disease that transmits from one person to another. And so we needed to learn more very quickly and respond very quickly. As WHO, we needed to support countries to respond very quickly. That has happened. Communities have responded to the outbreak. Governments have responded to the outbreak. The outbreak has actually been really well settled down. There are much fewer cases than there were this time last year, and so we're in a good place now. It's not finished, but the emergency phase is over. We now know what we need to do to keep working on this to prevent further spread.
Thank you, Rosamund. I wanted to come to you next, Andy. One of the things that we learned, and I actually had the privilege to hear the committee's deliberations as well, one of the things they highlighted at the beginning was the need for working directly with the community. And as they met each time, the need to continue meeting, working with the community. This committee I'm talking about met 5 times, and the last time was this week. And again, in their final statement, they said how important it was to work closely with affected communities. So Andy, can you outline who are the most affected communities with these outbreaks, and what does working with communities mean?
Of course, thanks for the question. So for this outbreak, there were probably 2 communities that are particularly important to us. There were communities based in Western Central Africa, where we've seen zoonotic transmission, animal to human transmission of mpox, followed by human to human transmission. And in those contexts, the modes of transmission, the way the virus is spread is varied. And then outside of that context, we started to see a growing outbreak that was largely linked to sexual transmission and close intimate contact largely, but not exclusively, within communities of gay, bisexual, and other men who have sex with men. Fortunately, these communities, which are in every region, are well connected to HIV and sexual health services. They have fantastic community leaders who are working around community health systems around sexual health, and those community systems mobilize really quickly. And I think several of our community leaders who really made a huge difference are actually joining us for this session today. And a personal shout out to Haroon Tulune, who really was extremely selfless and quite courageous in sharing his own story of infection from his hospital bedside in London last year. And it's messages like those from Haroon which help communities understand the realities of an epidemic like this, that helps people move quickly. So fast action is critical. And then, of course, communities also have really important insights into how best to control, how best to modify behavior, to introduce harm reduction measures. So for public health authorities in every country and in every region, the critical message is listen to the affected communities. They really have the answers.
And this is a perfect segue for us to go to you, Ochonye. You are the country director in Nigeria with Heartland Alliance International, a group that works with communities. Tell us what that has meant. What have you done through this outbreak to help people understand mpox and how to protect themselves?
Yeah, thank you very much. Again, thank you for the opportunity. One of the things we have done, because again, most of the time when some public health issues like this come up, it takes time to have dedicated funding streams. And so what we did was basically to integrate most of the mpox activities into existing community programs like Andy mentioned earlier on. So we have strong existing programs that deals with HIV, viral hepatitis, TB, and so on and so forth among community members. And so we have existing community-based organizations, local implementing partners that we have worked with in the last decade to build capacity in dealing with diseases that affect the community. So what we have done is to integrate the mpox learning through coordination, through risk communications, through ensuring that information that are passed from the NCDC, the National Disease Control Organization in Nigeria, who is actually operating a bi-weekly emergency operation center, within which some of us are part of those centers, but we are able to link the information we get from the emergency operations center down to the community through our community focal persons by cascading the information we have received and ensuring that whatever questions the communities have is also passed through us to NCDC and so on and so forth. So organizing the community and integrating this intervention is the way we have gone to ensure that the community is involved in whatever decisions that is made as it affects them. Thank you very much.
I'll come back to you, Ochonye, to ask what some of those decisions were where the community provided input. But just before I do, remind people that if you have questions for us and you're watching on Twitter, use hashtag AskWHO and ask your question about mpox. Otherwise, if you're watching on Facebook, LinkedIn, or YouTube, you can put your question in the comment section and our colleagues will find that and send that to us. So we have one question that I'll get to in a second. But just before that, I wanted to go back to you, Ochonye. So you said it's very important to involve communities so you can hear the questions they have, and then their input can have an impact on the decisions that are made. Can you give an example of how that happened during this outbreak in Nigeria this past time?
Yes, one of the clear example is the narrative that was beginning to emerge that, because a few community members, got infected and, were supported, in the process. And so there's this narrative about, labeling the mpox, as far as the communities that we serve is concerned. And so it was a conscious effort to ensure that in providing communication, in providing IEC materials, the words that we are used, in such materials are friendly and words that encourage everyone to take action and not, and making it suffer some of the issues that we suffered as far as even HIV is concerned, because HIV was being, stereotyped for, community, or the community is seen as, vectors, but we tried to ensure that those narratives are debunked, and the fact that yes, it affects our community, it is important to see our community as partners. It's important to use words that are friendly, and it's important to use narratives that make the community empower the community to continue to contribute to improving the response as far as mpox is concerned. So that's just one quick example that I would like to give.
Thank you. So we have a question from Sarwa Saif, and I'll hand this to you, Rosamond. The question is, what's the main cause of mpox? What's the main reason? And I'll interpret this as meaning, why did it take off? Andy touched on this. It's a disease that we've seen in some African countries before, and it continues on there in some countries. But we suddenly saw a surge last year, and many more cases all of a sudden clustered together. So can you explain what we know about the dynamics of what happened last year?
Sure. What we know about this particular virus, which is still known as the monkeypox virus, is that it transmits from person to person between people who are in very close contact. That can be a parent and a child. It can be two people together. It can be people living in the same setting, in the same household, who don't have much space. Sometimes people even share beds when they don't have enough space, or they share beds for other reasons. And so this is a virus that can also transmit during sex between men, sex between men and women. And therefore, this virus found a community in which it can pass frequently from one person to another because of sexual activity. So the virus gained a foothold in sexual networks where events occurred where people had a lot of active contact with each other. And so we saw this big spike in cases, and it took a long time to recognize that spike in cases because those countries had not seen mpox before, or they had seen very few cases before. And so it took a while for clinicians to realize that they were facing something new, to find out what the right tests would be, to find expertise to say, yes, this is what this disease is. So it took a few weeks, and during that few weeks, the number of cases was able to build up because there was no public health response during that time. As soon as it was recognized that this was not a new disease, but an old disease appearing in new locations, in new communities, in new environments, then communities jumped into action. Health authorities, health agencies began to roll out support programs to stop the outbreak.
Thanks, Rosamond. Now, you touched a little bit on how mpox is spread, but we have several questions on that. So I'm going to hand it to you, Andy, to take another kick at that and help us understand. So we have one person who's a student at the University of Rajshahi, who's asking for more information on the modes of transmission, and also why classmates who had mpox were then asked to isolate from everyone else. So if you could just touch on that, Andy. And this will also answer a question from Ephraim Abi, who's also asking about modes of transmission.
Great. So like many diseases, there are several modes of transmission. The main thing with mpox is to recognize that the blisters, the pox manifestations, the spots that appear on the skin, they really contain most of the contagious elements. And so it's through contact with somebody who's infected that facilitates transmission, basically. Now, in most cases, particularly when we're seeing non-sexual transmission, this may be within a household. We've seen this in Nigeria, for example, where OBB is joining us from, where a parent might be bathing and preparing a child for bed. So there's intimate skin-to-skin contact. It can also happen with others who are sharing a house if you're in contact, mainly skin-to-skin contact, but also if you're sharing towels or bed linen and that kind of thing. But what we did notice in this outbreak, as Rosamond was saying, was that it also transmits efficiently when there's intimate or sexual contact. and that's what we found in this one. And so some of the manifestations of mpox were a little different. So for some of the gay men, for example, who were infected in this outbreak, they may have had fewer poxes than we've seen in previous outbreaks in an African context. And they may have been similar to what you might see with sexually transmitted infections. So either quite mild or not easy to recognize. Now, of course, there are other extremes where people had very obvious pox marks across their bodies and hands and faces, etc. But essentially, the key mode of transmission is around intimate contact. And as I say, in this case, it was largely facilitated in the context of sexual transmission, but it's not the only mode of transmission, which again takes us back to this point that while there were certain groups that were more affected this time around, this is not a disease that is just facilitated through sexual contact. There are other modes of transmission that also transmit mpox.
So all of you have been explaining mpox transmission for about a year now. Andy, you just gave the most succinct answer you can, and it still took a couple of minutes.
Right.
It's really complicated. So, Otunya, I wanted to ask you a little bit about this because you were referring to it a little bit. You were talking about stigmatizing words, and we've got a disease that spreads through people being close together, whether they're close together because it's a parent giving a kid a bath, or they're close together because they're loving on each other. So that makes it really tough to explain because you're really exposing a lot about your private life, or people may be reading something into your private life when they hear that you have mpox. So how did you handle that in Nigeria? And what were some of the ways that you help people understand that really there's many ways you can catch this disease? And what's most important is that you get care and that you get better.
Yeah. Thank you very much for that question. So we learned a lot from previous diseases of public health importance, and we deployed some of that to the mpox situation when it came up. And one of the things we tried to do is to look at even the data, because within the first year of the resurgence, between 2017 and 2018, I think we had about 130 cases. So less than 1% of that cases is, among the key populations, so as far as, HIV is concerned. So what we have tried to do is to give a human face to mpox, to see that, look, anybody who is exposed, to either body fluids, like all of the things that Andy mentioned, can be infected. And so what is important is to prevent, yourself from getting infected. And if you are infected, you need all of the support that you can get, irrespective of your sexual orientation, irrespective of your social status, in the community or in the society at large. So we have tried to deploy that in the languages we use for IEC materials, and that is why in the Emergency Operations Center, we have community-friendly and community-led organizations represented in all of those committees, and so they are able to influence some of the languages that are used to ensure that it is friendly, it is supportive, it is empowering, and it helps people to take decisions that will help us to stay safe and to prevent new infections while we take care of those who are already infected. So a lot of education, a lot of information helps people to address all of their nuances around that leads to stigma, that leads to discrimination, and deprive people from getting access to services. So that's what we have done.
Thank you. So talking and listening as well. We have a few questions on vaccines, and we haven't touched on that yet, so I wanted to do that. We have Ayotunde Akibu, who is asking if there is a vaccine. Then there's Clara Teketori, who's saying, is there a recommendation for a preventive vaccine? And she's asking especially for healthcare workers. So Rosamond, perhaps you can take that and just talk to us a little bit about what we know now about vaccination, because we learned a lot in this outbreak.
We've learned a lot in this outbreak, Nika. Yes, so there is a vaccine. There are several vaccines for mpox, and they were first designed to be smallpox vaccines. But these viruses are similar to each other, and so even a smallpox vaccine can protect against mpox. And so these vaccines have now been approved for prevention of mpox. So yes, there are vaccines available. However, because of the way they were designed and the reason they were designed, they had never been tested in a global mpox outbreak before. So whereas we had every reason to think that they would be effective, we didn't actually have the evidence, the proof from studies. We had some studies, we had safety studies, but we didn't have effectiveness studies. So in this outbreak response, the vaccine has been recommended. Different types of vaccines in different locations have been recommended, and they have actually been used. At the same time, while they were being used, studies were done to assess their effectiveness. So we're beginning to see information now coming out from these studies that show that yes, these vaccines are effective against mpox, but not 100%. Really, almost no vaccine is perfect. And so the vaccines are effective around 80–85%. Some of them need one dose and some need 2 doses. And so remember, if you're going for an mpox vaccine, for any vaccine, it takes time for your body to build immunity. It doesn't happen overnight. You really need to wait 2, 3, 4 weeks, depending on what your healthcare provider tells you, according to the type of vaccine you've received, to wait until you've really built the maximum immunity that you can. And you may need to wait for a second dose. Having got that vaccine, then you should be protected maximally against infection. And even if that doesn't work, you should still be protected against severe disease. So we're really very lucky to have these products that were developed over many years after the eradication of smallpox in order to have safe products available in case of an outbreak. Now they were used in this instance. So yes, they are recommended for health workers who may be in contact with people who have mpox. Yes, they are recommended for people who may be at risk, including men who have sex with men who have multiple partners. They may be recommended for laboratory personnel. They may be recommended for other groups. So the countries where the group at risk was very clear during the last year, they were able to roll out the vaccine quite, I wouldn't say necessarily all so easily, but relatively quickly, countries were able to roll out vaccination for most of the groups at risk. However, in other settings where the groups at risk are more mixed, we've talked about different modes of transmission through direct skin-to-skin contact, transmission through sex, transmission through face-to-face contact, transmission through even contaminated needles or tattoo parlors, for example. It's harder to say who exactly is at risk and who should be vaccinated. So the first thing is that anybody who knows they've been exposed, they've been in contact with someone with mpox, they have been in contact, so they are by definition at risk. And so that person should, if at all possible, look for an mpox vaccine. It's called post-exposure prevention. So you've been exposed, then you take the vaccine. There's still a chance it could work. Again, not perfect, but there's a good chance it could work. Anyone who's very high risk, for whatever reason, the reasons that we've already all talked about, then that person can also, that community can also go and look for request vaccination. And this is pre-exposure. So you're protected even before you're in a situation that might raise your chance of getting mpox. So there we are. The vaccines are available. However, they're not available everywhere. And so you really need to speak to your health worker and find out if they're available where you are.
And I imagine it's something WHO and partners will be working on to try to increase accessibility, to do even more research, have even more clarity on how effective these vaccines are, when it's good to use them, and so on. There's a lot of questions we're getting that are similar. Questions on symptoms, for example. One of the things you can do, because we're not going to be able to get to everything during this live, is search in whatever your preferred search engine is. Search for mpox and World Health Organization, or mpox and WHO, and you should be able to find our web pages that have that kind of information. We're also updating our Q&A on the web with even more detailed information on mpox, and should answer a lot of the questions we're seeing. But I'll go to one now, and this one I think would be good for you, Andy. So Jolene Mott is asking, are mpox and HIV related, or rather, in what way are they related?
Great question. Short answer is yes, there is a relationship. The diseases themselves aren't related, but we're seeing some of the learnings and some of the opportunities for responding to the two diseases, and there's a lot of similarities. So first of all, both the communities that we've described who are in the zoonotic regions, so where we're seeing animal to human transmission in West and Central Africa, there's a relatively higher rate of HIV there among the general populations. And then within populations of gay, bisexual, and other men who have sex with men, worldwide, we know that levels of HIV are generally higher than the general population. So we've actually unsurprisingly seen that around half of people who've been reporting with mpox are also living with HIV. And many of the others are accessing HIV services, including, for example, pre-exposure prophylaxis, which is a treatment used as prevention for HIV. So we know that these people are accessing HIV and sexual health services, which is one of the reasons why we've been able to move quickly with the response to mpox, because we've got a community that's already tapped into health services, which is great. And many of those health services are delivered through the communities that are most effective. So in short, we're seeing HIV really appearing just in general across people who are presenting with mpox, but perhaps more worryingly is that mpox is largely quite a mild disease, but there are deaths. And we've seen that in the cases where people have severe mpox disease, a large number of those people are immunocompromised, and many of them have untreated and uncontrolled HIV. In other words, they've never had a test, they're unaware of their status in most cases, and they're learning at the same time that they find out they have mpox, that they also have HIV that's progressed to quite an advanced stage. And sadly, this has been the case for several of the people who've died in this outbreak have had both advanced HIV disease and mpox. But the critical talking point here for HIV is that most people these days who are aware of their HIV status are on treatment. They have viral suppression as a result of that treatment, which means, number one, they can't pass on the virus to others through sexual activity. And number two, they will not have any more severe outcome from mpox infection than people who do not have HIV. So in short, yes, there is a relationship. It's slightly complex, but it also underlines the importance of us delivering services. Now we're moving beyond the emergency phase, really looking at strong integration between HIV services, sexual health services, and how we handle mpox in the future.
Thank you. And there's more detail on WHO's site as well on that if you're curious. I'm going to do one last question. I'll take this one. I'll send this one to you, OBB. It's from Parvina Yakubova, who's asking, how did public health help to prevent the spread of mpox in Nigeria? Or if Parvina allows, I might say, what are you most proud of? What did you do in Nigeria that was really successful that you'd like other countries to know about as well? What worked?
Yeah, thank you very much for that question. So again, what worked is the fact that we were able to listen to the community, and we were able to answer questions. We were able to organize in such a way that we have contacts, we have emergency contacts, we have shared up from the community up to NCDC, the Nigerian Center for Disease Control, such that information is passing through. And we also educate the community. We have existing peer education programs. We have outreach community outreach coordinators. We have focal service providers in the communities that are already doing a lot of other work, mostly around HIV, STIs, viral hepatitis. So it was easier for us to integrate all of the education and communication and also contacts that people can leverage on to be able to get additional information about mpox. The other thing we have done is also to ensure that the community voices are heard when materials are being developed to create awareness, so that there is that ownership and there is that partnership that is existing. Nobody is left out. So that is something that has also happened. The other thing that has happened is also to ensure that nobody is left behind. So that principle really was helpful. I think lastly, I would say that there are different platforms that were used for providing information, because not everyone can come out in small groups for peer education and all of that. So virtual platforms were also used for providing information, closed user groups on Facebook, WhatsApp groups, and so on and so forth. So information integration, like Andy mentioned earlier, into existing program, and ensuring that there is that referral, cross-referral from the community level up to institutions that provide even advanced healthcare services.
So providing information, but also really listening clearly to what information people need, and even how they want to hear the information, where and how it should be communicated. So that's it for us today on this digital platform. As I said, if you want more information on mpox, you can use whatever search engine you prefer. You can you can rewatch this. If you only came in later and want to rewatch whatever your platform you are on, you can rewatch from there. And there's plenty of information out there, not just from WHO, but as OBB was mentioning, in Nigeria, for example, you can get information there. So just look for a reliable source for information on mpox. The good news is that the emergency phase of this outbreak is past. The good news is that we hope that all these organizations who became more aware of mpox will continue to work together on it as well. And that should help fewer people get it, and people who do get it, get the care they need sooner. So I just want to wrap up by saying where people have been watching from, and it's always nice to see you dropping your countries into the chat. So I won't read all of them, but some of them. So Tanzania, South Africa, Iraq, the US, Pakistan, South Korea, Bangladesh, Zambia, France, Morocco, Cameroon, Nigeria, Germany, Cambodia, Ethiopia, Iran, Uganda, Indonesia, Ghana, Burundi, Burkina Faso, Mali, Senegal, Zimbabwe, Myanmar, Equatorial Guinea, here in Switzerland, Argentina, Australia, Nepal, Cote d'Ivoire, Liberia, Mexico, Ethiopia, Peru. Thank you so much for tuning in. It shows you're curious and you want to learn more. And thank you as well for our panelists. We really appreciate your time today, and good luck in your work.